Welcome to the Baptist HealthTalk Doc-to-Doc Podcast, a conversation for physicians by physicians, providing insight on the latest in medical practice, research, technology, and innovation in healthcare. Join Baptist Health experts as they offer practical advice for clinicians covering a wide range of specialties. Cancer, neuroscience, orthopedics, and cardiovascular care are just some of the timely discussions you'll find right here on the Doc-to-Doc Podcast.
Good morning. My name is Dalibel Bravo, and welcome to the Baptist Health Doc-to-Doc Podcast. I am currently a orthopedic hand surgeon at Baptist Health Orthopedic Care in Miami, Florida. And today I'm here with Dr. Louette, and we are going to talk about carpal tunnel syndrome. We'll start off with the etiology of carpal tunnel syndrome, and the question that we've been asking for many years is, what is carpal tunnel and why does it happen? So carpal tunnel is a compression neuropathy of the median nerve at the wrist. So that means that there's compression at the wrist, and therefore we get symptoms at the median nerve distribution. And we'll go over those symptoms a little bit later. And who gets carpal tunnel? So carpal tunnel is more common in patients with underlying conditions, such as a high BMI, patients with hypothyroidism, and most common in patients with diabetes. But there is also a very large population who have an unknown etiology. We do not know why those patients get carpal tunnel. What we do understand is that carpal tunnel can be related to repetitive exercises, some that can be encountered in the work environment and some that can be encountered due to extracurricular activities. We also have seen that carpal tunnel is not related to keyboard use. So there was an article published in JAMA in 2003, and it was mostly based on surveys where they, over in Europe, they surveyed over 9,000 patients, and they were able to determine that keyboard use was not a factor in contributing to their carpal tunnel syndromes, although mouse use was a factor. The symptoms, which I mentioned that we'd go over for carpal tunnel syndrome, are those that affect the median nerve. So the median nerve provides both sensory and motor function distal to the wrist. In terms of sensory, it contributes to sensation at the thumb, the index, the middle, and half of the ring on the volar aspect of the hand. So many patients will come to me and say, I have numbness in my entire hand, or I have numbness on the back of my hand. So that isn't necessarily carpal tunnel syndrome, although many patients cannot differentiate where it is numb when it happens. This usually occurs at nighttime. It's because of the position of the wrist at night. We seem to sleep with our wrist inflection. And then we'll go over why this is important later in terms of treatment options. So when this happens in the middle of night, patients can't really tell which are the fingers that are getting numb. Although there are other times this does occur. When driving, it can happen when holding the cell phone. And during those more awake hours, then patients can kind of tell where the numbness is, and then they'll be able to more reliably tell you that it's the first three fingers and not the other two. The small and the other half of the ring finger, the ulnar half, is sensory, comes from the ulnar nerve. So that's in terms of sensation. And then in terms of motor, we can have weakness in grasp, and then primarily we have weakness in the abductor pollicis brevis, which main purpose is to abduct the thumb, and we can test that in the office. When we have motor weakness, then that is a very late finding, and we have seen that in our studies, which Dr. Louette is going to talk about shortly.
Okay, so how to perform an exam. I'm Dr. Willett, and I'm Chief of Hand in the Baptist Health system in orthopedic care. And One of the keys to doing this is really just do a quick neurologic exam on all your patients, because you would be amazed at the amount of carpal tunnel and things that you turn up that are related to other complaints. So in performing the exam, I've always used Semmes-Weinstein testing, although you can argue 2-point discrimination, either static, in other words, it's not moving, you just use the 2-point and figuring out the distance that people can feel, and or moving those 2 points on a fingertip. And that is the more reliable that comes out of there. But at the same time, I have found the most reliable is Semmes-Weinstein. And you can order Semmes-Weinstein monofilaments off the internet, and they have them in the different grades from normal light touch, diminished light touch, to early loss of protective sensation, then loss of protective sensation, then complete loss of sensation. And this is a really good way to be able to tell how severe their sensory deficit is. And many people don't even feel the numbness when they're even out at loss of light touch and or early diminished protective sensation. And so I think it's really important, and many times they're stunned that they aren't feeling as they should be. So a sensory exam is really crucial, and something that's objective, not their gestalt, not your gestalt, but something that you can get objective. So pick whichever one that you feel the most comfortable with, but do it every time. The same with the motor exam. And so make sure that the forearm is completely supinated and the thumb is held up in abduction, and then you get them to resist you. If they are supinated, if they're pronating their forearms, they're using their forearm pronators to make up for the loss of that thenar muscle. So you're going to miss the exam. You're going to miss the fact that they're weak in their thenar muscles. This is also, if you do it in full supination and make sure their forearm stays there, you're going to pick up on any atrophy that they have. And again, a lot of patients can't quite pick up on the fact that their hands are weaker, but they complain about being unable to open a water bottle, things falling out of their hands. They're breaking their porcelain and their glassware. And these are the things that they actually notice. So it's really important to have both the provocative signs, which are 95% sensitive. In other words, if they complain of numbness and tingling, particularly at night, driving a car, reading a book, on the computer, that is positive provocative symptoms that are symptoms. Then when you do your compression test, compressing both at the wrist, which is a Durkin sign, or a pronator sign in the mid-forearm, if either of those are positive, that's another positive provocative sign. So that's a 95% sensitive test. If people have those things, they have carpal tunnel. Then I add in the motor and the sensory exam to confirm it, and then I add in the EMG nerve conduction. Now, I've been doing that since the late 80s, but it wasn't until recently that it was really required as felt to be a clinical practice guideline recommendation from the Journal of American Academy of Orthopedic Surgery, and that was in 2009, both an EMG and an exam. The problem with EMGs, are they a gold standard? No, they are not. They're electrical. And the way to think about this is, how easy is it to find a car mechanic that truly understands the electrical wiring of your car when that starts to go south? Difficult. And well, this is no different, because electricity has a lot of personality to it that can make it do different things. So for instance, EMG nerve conductions are 30% false negative. In other words, they say you're totally normal when in fact you do have carpal tunnel and you have all the other things going on. And I turn that up routinely, finding people like that where they have all the positive provocatives, they have the deficits on this, exam. And so the bottom line is, you're treating a human, you're treating a person. And so if their exam is positive and indicating they've got carpal tunnel, even though the EMG nerve conduction does not, you still consider surgical release. On the other hand, if somebody has very severe nerve conduction findings, that does lend itself more to being a positive result. And there are a number of those people that don't have any provocative signs and have normal sensation. but severe atrophy, severe weakness, and severe findings on nerve conduction. And those people, I say, you need to really consider releasing this nerve, because when it decides to really go south and have troubles, you're going to all of a sudden have searing pain that's going to cause you to go to the ER. Everyone's going to look at you and say, well, it's carpal tunnel. Go get it released. It's not an emergency, only it's going to be an emergency to you because it's going to be so painful. It'll be the last gasp of that nerve. And so there's all kinds of combinations that you see in these nerves, and you have to use kind of these 6 things to help guide you. So for treatment options, again, you've got time if they don't have pain or they have, minimal symptoms in terms of splinting at night so they don't sleep in flexion or hyperextension, because either direction, flexion or hyperextension, as shown by Gelberman and Bjorn Radovic looking at compartment pressures in the carpal canal, will get you an increased pressure. And then add to that anti-inflammatories, because we know that there's an inflammatory response going on to the ischemic pressure in the carpal canal. And but we also know that it is not synovitis. For the longest time, hand surgeons kept thinking that this was related to synovitis, but in fact, all the way back in the neurological literature in the early 60s, where biopsies were done of synovium, it's not synovitis. And so the neurologists had it right from the get-go. It is a compartment syndrome. They didn't know to call it a compartment syndrome, but they knew that it was an ischemic phenomenon, and the pathologic evidence within the synovium around the flexor tendons was that of ischemia, not of inflammation and synovitis. So that also is one of those facts that's slowly been dying out. With regard to genetics, metabolism, nutrition, and hormone imbalance, which is basically out of the JAMA 2006 article, which was looking for the major causes of carpal tunnel and making sure that was it related to carpal tunnel overuse with keyboards, et cetera. And so that's one of the papers that also said, no, it's not related to keyboards. Well, very interesting. There's a gene 17, which is related to compartment syndromes, entrapment neuropathies. And so actually one of the reasons for this search like this was because one of the first EEOC lawsuits against a company for genetic profiling was a company that was taking people's blood when they came to interview for a job and looking for gene 17. And if they had gene 17, they wouldn't hire them. Now, they weren't telling people that was the case. And so people who had the potential to develop carpal tunnel syndrome would be actively discriminated against. This is 2000. And yes, so that's one of the reasons for the HIPAA laws, actually, was the genetic discrimination. And so very interesting. So with that, that's one of the reasons for all this different looking at the reasons for these things, et cetera. So gene 17 is in there, although I don't know any of us trying to screen for that or looking for it, although that might be worthwhile for a research project at some point if somebody's interested. Metabolism. We know that carpal tunnel is related to diabetes, renal failure. A lot of times the people with transplants who are on immunosuppressives and difficulty at handling their fluids, et cetera, will get carpal tunnel syndrome. And so you need to look at kind of their whole health. Nutrition is also an important one. And if you are eating things with a lot of salt, but you don't have a kidney that can handle all that salt, you're going to swell. You're going to swell. These are narrow compartments, and your nerves are going to get entrapped. And the same thing happens with nutrition. So one of the things that I have found is that if I can get people to go on an organic diet to reduce the number of toxins in their life, it will really help them. And there's a number of websites out there that will help you navigate the grocery store and the drugstore, looking for the least toxic products that you can find for your shower gel, your soap. Anytime you put something on your skin, 30 seconds, it's across your bloodstream, across your skin into your bloodstream. So even skin care products you need to be aware of. Hormone imbalance. We're getting into a lot of thyroid issues these days, both hyper and hypo. And we also have a lot of estrogen, testosterone issues going up and down, both with people taking them, both with people getting hormone disruptors. Again, that's all the toxins, the plastics. People are trying to get a lot of that out of the plastics. The liner in the can of sodas actually potentiates type 2 diabetes. So this is the stuff that we're eating and we're putting on our skin is literally a landmine of toxins. So if people will clean up some of that, it's amazing how that will help diminish carpal tunnel. The other thing is when I get a recurrent carpal tunnel, in other words, we've released it, and sometime in the last 5 to 10 years, and they come in with new carpal tunnel symptoms, I go, no, we got to get you checked out on your hormones and metabolism and all this stuff. So I will send back requests to their endocrinologist or their primary care docs on what to be looking for. Most recently, I sent somebody back looking for parathyroid hormone issues. And the endocrinologist was like, oh my gosh, how the hell did your hand surgeon know this?
Not just any hand surgeon, I'd say.
So it was parathyroid. So we've got it under control. And when that happens, then their carpal tunnel vanishes. So you don't have to reoperate on all these people. Get their hormones in balance, and you will find a lot of this corrects. So diet, exercise, bracing, hormones. And Dolly, what kind of things are you seeing, and what have you done?
So I think that, it's been very important for preventive care in our patients today, right? They come to you sometimes before symptoms starts or early during symptoms, and they want to know what can be done other than surgery, right? And then all the patients walk to my office and they say, you're a surgeon, you want to do surgery. I tell them I do also not do surgery. We do talk about their general health, that they'd be surprised that if they take care of their underlying conditions, the most common one that I see is just a high BMI. Most of my patients with carpal tunnel are overweight. And I do try to discuss that with my patients, and they're aware of it. And then the other most important predisposing factor I talk about is diabetes. So the other, big subset of my patient population with carpal tunnel syndrome are diabetic. And I take advantage to address this by always getting an A1C in my patients preoperatively. If it's over 8, then I have been asking them to decrease their A1C, to at least try, to get a better control of their diabetes. I think in our hand literature, we don't have specifics for A1C and surgery, but we do have it in the orthopedic literature. And so I'm using that as my guideline. And I've had patients tell me, thank you, because I really want to do this surgery. And now I have a motivating factor to do it. And because, could I do carpal tunnel with over an 8? Maybe, how high is the risk of infection? I'm not entirely sure because we don't have that data. But if it helps my patient get healthy in a few months without detrimenting their overall care, I think it's worth it. What do you think about that?
I definitely agree. I also have a peculiar viewpoint on this, having been a type 2 diabetic after my first pregnancy. And then it got worse with the second pregnancy. But I was one of the people that had Diet Dr. Pepper or Diet Coke for breakfast every morning as a medical student, a resident, and that sustained me as my caffeine hit through the day for pretty much 13 years. And then as a fellow, and I realized that maybe that stuff was really hurting me, so I cut it out, but only after the kids. And I will tell you, that even when you starve yourself and exercise yourself down to Auschwitz levels of caloric consumption, you're not going to lose weight easily, and you're never going to get back down to your baseline. And that's because there's some hormone disruptors that have occurred, and then they stay permanent. So that's one of the other chats that I go through. So I totally agree with you. And in that JAMA article of 2006, 80% of people with carpal tunnel in that article had an elevated BMI. Now, the problem with BMI is how you measure it as well, because it's height and weight. So consequently, Arnold Schwarzenegger and Demi Moore at their most fit would be regarded as overweight. because they had muscle, and muscle's heavier than fat. So we're going to have to do some revisions to BMI and the way we look at it in the future. So right now it's pretty gross. The other thing is that patients can do some things. They'll lose some weight, but they will never get back down to a baseline weight. And that's in the ghrelin hormones. And those are made by your stomach. And they basically are the insulin resistant hormone. They get in front of the cell and they basically tell insulin, oh, you can't work here. And so there's going to be no entering of glucose here. So glucose then sits out in your bloodstream. Where does it go when it can't get into a cell? It goes into fat or pee, which is one of the reasons why you have to know where the bathrooms are in any place that you go, because, man, it comes on very fast and you got to go. And you can go to dinner with your family, eat the feta spinach salad with the diet vinaigrette and the diet iced tea. They've all eaten all the high-fat appetizers and shared them with each other. Each had a full dinner, a dessert, and the cappuccino with the biscotti. They didn't gain a pound and you gained 5. And that's the problem with type 2 insulin-resistant diabetes. And so that's one of the things I actually take the time to explain to people, and things that they should look up and people that they should go listen to see what other options they have for diminishing that. And so we can go through that in more detail in more of a nutrition lecture, and all the different hormone disruptors and how they affect orthopedics. So that actually would be a good podcast of, kind of natural medicine for people. And so, so that's basically the big ones on the diet, exercise. I have not had a problem with people having infection rates with diabetes, no matter how severe they are. And my attitude has been, I'm going to release you no matter what, because you're losing sleep. And sleep deprivation is a killer. There's a reason it's used as a torture device. And therefore, we're going to get this off. And even if we have to chase an infection, fine, we'll chase the infection, but we got to get the pressure off the nerve. And so I'll literally operate on 100-year-olds. So I don't have any criteria for saying, no, I'm not going to operate on you. I will operate on everybody, but that's because I'm approaching it like a compartment syndrome. And so a 100-year-old says, I can't live another day like this. Even if they only have a month, I'm not going to let them live another day like this. We're going to operate. So that's, I have a peculiar attitude towards that, but I have not had anybody come back and have a horrific event of, a sepsis or having to open things up to a big wide open incision because of pus or whatever. But you stay on top of it. And there's a couple of other tricks in there surgically, which we can talk about when we get into the releases.
Yeah. I think that's a good segue to talk about the releases, right? So we can start off with, we do want to talk about today different compression neuropathies, carpal tunnel being one of the most common. We started off with that. So then we can just go on and talk about the release for the carpal tunnel, and then we can start at the wrist. So how do you like to perform your carpal tunnel releases,
Well,
Dr. Lett?
When I first started, there was only open. And so I made sure that my open incision was always more ulnar to stay off the median nerve, so the median nerve would have gliding after the surgery and not be up against a scar. And I got invited to go see the ECTRA Chow release in 1989 by a sports medicine doc. And I said, well, okay, I'll go with you. And so we went up to Orlando and went to this, big course that the guys from the Indiana Hand Center were putting on. And I went up with the attitude of, I'm not going to do this, but I want to know, why I'm not going to do it. And so at the course, and I'm going through this and I'm looking at it and I'm going, holy Toledo, I'm going to do this. And so I come back, and the only place I could get to buy the equipment is a private hospital and the VA. Since that time, 1989 to now, even though we've got many different ways of doing it, and I've tried the AG, it just didn't allow me the vision that I wanted, that I could get with the Chow. And I've looked at the others, To me, again, they were changes in versions of the AG technique. A lot of people came saying, I had this AG technique, and it was so.
I thought you mean the single
Single portal technique. It took me a year to get over it. I said, I'm never doing this again. But of course, the other opposite hand starts to really bug them. And at that point, their symptoms are getting so severe, they're like, I guess I'm going to have to go do this and just take my medicine for a year. And they come in to talk to me, and I say, look, I do it differently, but it's just going to be 2 incisions instead of 1. And they look like they're going up in front of a firing squad. Afterwards, the first patient said, if I'd known it was this easy, I would have come a lot sooner. Now, that's just a story. The second patient, you're going, I think we got a trend here. But, the third patient, that's it. Then you got a trend. And somehow or another doing it with the 2-portal technique. And I suspect that what the difference there is that I wash saline through the carpal canal. Now, one of the things that you don't realize in a compartment syndrome, in a narrow space like that with ischemia, what's happening? The tissues are making inflammatory enzymes called cytokines they're part of the pain stimulus to tell you to do something about this. And so I've washed them out. Very few of my patients complain of any pain whatsoever. And most of them don't even take a Tylenol. And we don't give narcotics for post-op pain at all now. So consequently, I'm sticking with the 2 portals. Even if I change up to a different technique, which I have not at this point, but I'm going to stick with the 2 portals to wash the cytokines out and to make them more comfortable. And so that's my philosophy at this point. And if I get something to change it, well, cool. But I don't think so. I think I'm kind of stuck in my lane, so to speak. So, talk about
you. So I do the single portal technique. I train mostly with mini open, and that's what I did mostly in residency and mostly in fellowship. And now in my first year out in practice, I started with the mini open, and then I wasn't liking how I felt like I had to look after my post-operative incisions, and the patients complaining of the incision on the palm and pain. Although with the single portal, you still get the pillar pain. So I think it was mainly just aesthetics. And I went to a course for the single portal using the Segway. And I liked it. And so after the course, I became a little more comfortable doing it in my patients. And then I've been able to compare how my patients were doing, with the mini open versus the single portal incision, at the wrist crease. And they did great. They I think returned to work quickly. They had no pain, but not that many complaints, not that many wound issues. We know from our literature, and this has been borne out through many studies of mini open versus endoscopic, single versus double portal, that they all do the same at the 1 year post-operative, that patients with the endoscopic carpal tunnel do go back to work quicker in that first 4-week post-operative period. It's usually like 1-2 weeks versus 4 to 6 weeks for open carpal tunnels. But at 1 year, they all do exactly the same. So, any way technique you do is perfectly acceptable as long as you get a complete release. And I know Dr. Louette will say that's the most important, is getting a complete release, no matter which way you do it, a safe and complete release. And then in terms of washing out the cytokines, I do have a practice that one of my fellowship attending taught me. I'll do a shout out to Dr. Liss, was that I put in the bulb syringe and I wash out and I feel for it to go all the way up the carpal tunnel distally, and then I do it proximally. I do that as well. And I was doing that mostly to confirm to myself that it was all released, but I do like that also seems to wash out the cytokines. I think that would serve a similar purpose. Yeah, so that's how I do the carpal tunnel release. And then post-operative care, it's pretty simple. I have my patients keep their dressing on clean and intact until I see them in the office. I see them a week later because of my office hours and the way that it works. I know that I think Dr. Wet sees them the next day with the help of her nurse practitioner. And then it's motion, move your hand. It's surprising how patients are like, I can't use my hand at all, right? And you're like, no, you want to use your hand and you want to move it and you want to move your fingers. Just don't carry anything too heavy that could put in jeopardy the integrity of the wound healing. And it's a completely soft tissue procedure, so it's not too painful, like Dr. Luet mentioned. And nowadays, we only prescribe Tylenol and ibuprofen for these surgeries, and it's more than enough medication for our patients.
And I have a few other comments to my patients, and that is because we're in Florida, and you all characters here in Florida.
Yes.
So I say, look, I want you to do everything, dress and undress yourself, feed yourself, cook, et cetera, et cetera. The one thing you cannot do is be a Florida man or Florida woman, i.e., you may not go wrestle alligators, you may not swim with dolphins, you may not go fishing for marlin. Now, most people start laughing at this, and I say, but you don't understand. I've had people actually do this. And I'm like, no, that you can't do, because you can't get in the water, particularly here in South Florida, because we're full of all kinds of microorganisms that love to walk in those wounds. So all I want you to do is stay clear of water for 2 weeks. Just give me that, and then you can do and be whatever you wish. And so by putting it that way, I get everybody going, and I have very few people afraid to move and afraid to do things. But that's what that first day post-op check is, really. There are two things we're looking for: strep, because we live in this community here, and they're moving and making sure that they're really moving. And one of the things that I tell residents patients, in order to help them understand why I'm so paranoid about infection, is one of the board questions a few years ago was, what bacteria lives in tulips? Why that was important, I'm not sure, but the answer is E. coli. Now, tulips, do they live in Florida? We're a zone 10 growing area. By the way, there's only one other zone 10 in the continental US, and that's in Yuma, Arizona. So we're it. And so what grows in our front yards? Bromeliads, orchids, etc. What lives in those? Frogs. We've jumped entire phyla. So we are surrounded by bacteria. You're living in a goldfish bowl. And we know that goldfish bowls and frog bowls have things like Mycobacterium marinum, which we get a lot of around here. So with that, I just warn people, please be careful about the water. That's the only thing that I care about. Everything else is carte blanche. Do whatever you wish. And that helps people stay focused and not worrying about what they're doing. And then obviously the second week we take out the stitches, and then I'm looking for staff at that point. So at each point, I'm looking at them. So let's just talk about that wound care for a sec. If I have a diabetic patient that I'm particularly worried about, I will add gentamicin ophthalmic drops in their wound, as long as they're not allergic to gentamicin. And that gives me some bacterial punch for about a day. I also clean their arms with alcohol and peroxide, and then the prep. And then when we're cleaning up the wound to put the dressing on, I clean it again with peroxide. Peroxide's your hammer. No bacteria can learn how to resist that. It's a hammer. And so the beauty is you clean up whatever is coming out of their pores and whatever's coming out from underneath their nails, etc. Because trust me, that stuff's all hidden, and you catch it again. And so they're leaving the OR having been prepped initially, and the chlorhexidine will last for 3 days after you've prepped them, in addition to the peroxide, which annihilates the bacteria that have welled up out of anywhere. So those are my tricks for keeping people out of trouble and just being a hawk on infection in South Florida.
Yeah, those are some good tricks. But yeah, I agree. I've had to adjust some of the things I tell my patients post-operative because we're in Florida, because I had a patient the other day that I did surgery on. It was an open distal phalanx fracture. It kind of looked like a Seymour in an adult, but the distal phalanx was coming, through the nail bed. and he was on his boat in the Keys, and he's like, this was on like a Thursday. He's like, oh, I'm gonna go next week to go lobster diving because it's lobster season and I can't miss it. I bought this waterproof bag. It has a vacuum. It's totally safe. Don't worry, dog. I'm just gonna go diving with this pin in my finger, this open fracture, 1 week post-op. And I was like, no, absolutely not. You cannot do that. He's like, oh, well, good thing you mentioned that I couldn't, get it wet. And, so I definitely have to tell these things to my patients too here in Florida. I have to be like, no jacuzzis, no pools, no ocean, no fishing, no deep sea diving.
Right. That's why we put it into the Florida man, Florida woman thing. Most people in the rest of the United States don't believe the Florida man, Florida woman stuff that comes up on the internet. I go, no, it's all real. It's all real. And most Floridians start laughing. That's what makes it stick in their memory, that you said no water.
Yeah. So do you have them when do you let them shower with like soap and water? Is that 2 weeks, or do you do that a little sooner?
Once they take the stitches out, they can get in the shower, they can do a normal shower, but nothing else for another week after that.
Yeah. Okay. Yeah, I have a similar protocol. I definitely see a lot of concomitant trigger fingers with carpal tunnel syndrome and distal radius fractures with carpal tunnel syndrome. And in other compression neuropathies, which we're going to talk about in part 2 of our podcast. Everybody stay tuned when we talk about concomitant compression neuropathies. But what are some common conditions that you see carpal tunnel syndrome with?
3 major ones that I see. Trigger fingers, because the carpal tunnel will cause swelling distal to the compression of the median nerve. That's classic of all compartment syndromes. And so the trigger fingers get ticked off. The other thing that's in there is CMC joint osteoarthritis. And so many times I will deal with the carpal tunnel and the CMC joint simultaneously. But the key is that they have to be uncomfortable turning a key in their front door. So if they can't get in their front door because they're hurting at the base of their thumb, okay, now we'll talk about it. And I always look for carpal tunnel as part of the whole thing, because we know from rat studies, actually, that if you will inject muscle with botulinum toxin, effectively paralyzing it or weakening it, and then saline in the opposite leg, you will get osteoarthritis quicker in the leg that has the weaker muscles. So weak muscles will actually predispose you to increasing your arthritis. So be on the lookout for that. But the other thing that comes in, and these are highly sophisticated individuals that know where they are in space. These are high-level athletes, both from the NFL. I'm thinking of one in particular, and another from the NBA and tennis. And these people come in, complaining of TFCC and/or wrist instability. But if you are doing your neurologic exam every single time, every single patient, you are going to pop up carpal tunnel. And who knows what's chicken and egg? Was it the instability that caused the carpal tunnel, because now you got swelling around the joint, et cetera, or was it the carpal tunnel and the weakening of the muscles that then caused the wrist not to be as stable because you're overusing other muscles, et cetera? Can't tell you, but when we fix their wrist instability, we release their carpal tunnel at the same time, and their nerve conductions are positive. So with that, always be looking. Don't think of an athlete, a young athlete in the NFL, in the NBA, in college sports, as not having anything. And it's only the wrist instability. It's more than that. The other thing recently that we've turned up, so you can be on the lookout, although I have no clue how common this is going to be, but after that second booster, we had a number of high-level athletes come in with weakness of the entire arm that the booster had occurred in. And of course, what they come in complaining of, their TFCC, because now they had weakness and the TFCC was more symptomatic. Only because we do that neurologic exam every single time. And when we picked up on the fact that their thenars were weak, their intrinsics were weak, their extensors were weak, and then we said, whoa, we went on and looked at the biceps, triceps, and the deltoid. Those are the next 3. And it takes you only 3 minutes to do all this. Very quickly, we found the entire arm weak. The first kid, I said, whoa, you might have a, meningocele or a meningioma in your cervical spine. I mean, because you don't see that in a 21-year-old. Sent him off for the EMG. Sure enough, he did have a brachial plexus, but it resolved. Everything resolved within 2 months, 3 months of this. So he went on to do fine, and another two, similar pattern, and it all resolved. So there's a lot more to these vaccines, but you may be seeing some athletes with that. Go conservative for a little bit, check when their booster was, and see if you can relate it to that.
Yeah, that's interesting. I have seen a lot of young patients come in with compression neuropathies, particularly carpal tunnel syndrome, which I've released and found very odd, like 18, 20, 21-year-olds with carpal tunnel syndrome. And I've been very hesitant to do surgery on them. But once I get an EMG that shows anything that's, moderate to severe carpal tunnel syndrome, then my first step is usually operative. I can give them the choice to watch it closely, not with severe carpal tunnel. I usually take that straight to the operating room. And if they are great and the patients feel better. And so, yeah, I agree that we should be on the lookout for young patients with these conditions and, treat them seriously.
By the way, the young patients that you're seeing with that, I'll tell you, most of them are gymnastics, cheerleading, a flyer, or, an anchor, because that's really gymnastics, and the CrossFit stuff, which younger and younger people are getting involved in. And one of the things that I tell these young people, you need to back off, because you really can't make muscle until you're 18. That's just genetics. That's just the way we're made. So for you trying to strengthen up at 14, 15, and act like you're 18 to 21, you're going to damage yourself. You're going to break down your growth plates. You're going to do some other interesting stuff. Back off. Give yourself time to grow up. And unfortunately, we've begun to push everybody faster and faster to be more at these younger levels. And I always point out to them, I say, who get to be the superstars in the NFL and the NBA? Were they superstars in high school? And most people think about it a minute or so and they go, well, no. I said, exactly. Back off. Save yourself for that NFL, NBA, Major League Baseball career. Don't go too hard, too fast. Okay. So that's another thing that has carpal tunnel, and really nobody's really talked about that, but I have a number of patients, you have a number of patients. Good study.
Yeah.
And if anybody,
that's good.
Right, and if anybody in the community wanted to join in, be part of that, no problem. We're very generous on those kinds of things. Jump in. Let's do it.
Yeah, sounds good. Well, we'll make sure that I'm sure they provide our contact information at the end of this podcast. And if anybody wants to join us in young patients with carpal tunnel study, let us know. Well, thank you, Dr. Louette. This was a great talk. I appreciate your time, and let's do this again soon.
Thank you.
To find out more about the topics covered on the Doc-to-Doc podcast, please visit physicianresources.baptisthealth.net.